you, the organizers, for calling me to talk on AI in lung cancer. I'm going to largely speak about AI in pathology and applications, but there are a lot of similar things happening in radiology, and obviously there's a lot of things happening in genomics, AI-driven genomics. But that is not my direct area of work, and I would like to restrict myself to the pathology side of things and a little reference of where we have done collaborations with radiology teams and other people. I'm going to talk about the applications and the impact it is possibly can have on clinical management, as well as our understanding of cancers, as well as the problems that we face and why, despite all the papers and all the things happening around the world, it is still not seeing the light of the day, and why it's still not being used in clinical practice. So, diagnostically, whenever we get a biopsy or any tissue, essentially the first thing we do is whether there is a tumor or no, and then we first classify what type of tumor and things like that. Now, this is just a representative slide. There are obviously many more histological types and diagnoses there are different kinds of tumors that are possible, and this is one of the first steps that we do. Obviously, after that, we do a lot of proteins, immunohistochemistry, we do genomic studies, whether targeted, focused, or we do more broad-based NGS-like studies, etc. And the entire process of all of this is, the purpose of all of this is to essentially not just diagnose, but also find therapeutic and prognostic predictive markers for any cancer type. So there's a very general rule that is applicable for everything. Now, the more we investigate, more tests we do, the time that it takes and the money and effort that goes into doing all of these studies is obviously increasing dramatically. So today, a lung cancer patient, the time to starting treatment is at least 3 to 4 days for a targeted therapy, 3 to 4 weeks for targeted therapy. If you want to do all this test followed by genomic testing, the turnaround time being at least 2 weeks minimum, 2 to 3 weeks. So AI essentially is enhance this particular workflow and try and reduce the turnaround times. That is one of the things that we do. Plus, there are additional things that we have previously never done or were very difficult to do in a conventional sense that we can possibly do with all of this. So broadly, the AI or deep learning or ML-based applications, we divide into these kind of broad categories that are readily available to us. All of these methods are generally focused what we call discriminative AI, where we try to dissect out the tumor tissues into, or tumor images into, okay, this is EGFR mutant image, this is EGFR wild type image, or this is a resistant image, or a sensitive image to a particular kind of therapy. There's a lot of role for generative AI that is now evolving, but we are still not there. There's still early stages of generative AI. Currently, generative AI is largely focused on languages, but the vision and the image-based generative AI models are also coming up. So how accurate are these methods? So this is one of the papers, early papers for classification of histological tumors, based on histological examination of tumor tissues and deep learning. And this was done specifically, example is from lung cancer. And as you can see, the accuracies of these range in 0.8 to 0.9. The point that I want to highlight is that these accuracies differ for different histological types also. For example, the squamous carcinoma is much better recognized by the deep learning methods than adenocarcinomas. And there is a difference in the accuracies whether whether frozen tissues are seen versus FFP tissues are seen, or whether the resection or as a biopsy. There's a lot of differences that can happen. So a model which is trained on only resection tissues may not work equally well on biopsy tissues in this scenario. So this is relevant because most of the models that are currently available or published are based on resection tissues from Western countries where tumors are smaller. Most of them get resected. But in our country, most of them don't get resected. Most of them are very small biopsies, or they are from metastatic sites, which is not currently included in all of these. ISLC grading is obviously a proven prognostic factor, and based on the proportion of the different histological parameters. The deep learning or image processing based grading of this is obviously very accurate and replicates the prognostic potential of ISLC grading by itself. But what it also allows us to do is actually quantify and qualify the heterogeneity of the entire thing in a very accurate way. Now, this allows us to really build things further and goes way beyond what a human pathologist would see with his eyeballing and looking at quantifying whether it's 20% or 30%, which has a lot of inter-observer variation as well as intra-observer. I may not call the same thing 20% if I see it tomorrow. So based on the assumption and the presumption that that genomic mutations, genotypic changes also manifest as phenotypic changes, we are now also able to now predict genomic mutation directly on H&E stain section. Now, if we compare it to the AUC curves of histological typing, these AUC curves are much lower. The accuracy currently ranges from around 70% to 80% at the max. But it depends from tumor type as well as also on the mutation that we are trying to detect. But again, the real advantage of this is that it allows us to now visually quantify heterogeneity of tumor tissues directly on the H&E stain slide and not wait for 2 weeks, 3 weeks for the entire genomic study to happen, at least in some cases. This is another example from the same paper, which essentially went on to show that that based on these histological image-based analysis, we can even then subclassify further, where EGFR high risk, EGFR L858R or 19 deletion mutations patients could be further classified into high risk of relapse versus low risk of relapse. So within a single cohort, we can even dig this as an independent prognostic marker and separate out low risk patients as well as high risk patients. Essentially, we are trying to go towards more and more personalized and precision medicine. So as I said previously, essentially one of the things that it will do is reduce the turnaround times from 3 to 4 weeks to a few days, at least for a certain set of patients. This is our example that we have currently been working on, and we have hit a bit of snag, which I will highlight, but we are trying to work on this further as we go ahead. Obviously, we can do the histological typing very accurately, and our model, the mutation prediction model for EGFR is also doing significantly well when we do a standard training and things like that. But what we wanted was not a model which works only on Tata Hospital. We wanted a model that works on multiple different hospitals and multiple different data sets and things like that. So we decided to test the generalizability of the model. And so we first trained the model on TCGA and then tested it on TMC dataset. And we can see that the accuracy drops dramatically. It is practically not usable for clinical practice. And we reverse the process and also see the same thing happening. So what is exactly happening? The tissue types are different. There's a lot of carbon pigment in Indian tissues, Indian lung cancer tissues, as compared to the Western. And the Indian patients' tissues are also smaller because they are biopsies and tissues, very small tissues, as compared to the Western data sets which have bigger tissues. So what the model is focusing on is something that is being studied. There's some similar work happening in radiology side, and that has also been published recently. So apart from these complex things, there are a lot of simple things that again also do once you actually digitize all of this. So the precursor to doing any of these things is the data has to be digitized. And once you digitize it, even if you don't have a complex AI deep learning based model, there are a lot of quantitative things that can happen. For example, in neuroendocrine tumors, you would do a MIB1 quantification or even do mitosis quantification for grading the atypical versus typical carcinoid and things like that. And instead of simply eyeballing, we can do a quantitative measurement directly on the digitized slide in a much more accurate way. And many of these softwares are freely available. So if you have digitized slide, these things can be done on the class, even today. It is also shown, obviously, that pathologists who use computational methods like these, where you use computational tools, will obviously do much better as compared to pathologists who won't use this kind of tools. Another problem that is there that the models don't perform equally well in all cohorts. One of the examples was EGFR that I mentioned in our cases. And this is also another paper which showed that they tried different models. And the 3 cohorts simply would not have the similar performance in terms of accuracies, positive predictive value, and things like that. The third problem comes in when the predictive, what we are trying to predict starts becoming more complex. Instead of binary squamous versus lung, EGFR mutant versus non-mutant, if you start doing more complex predictions like the patterns, there are 5, 6 different patterns of lung cancer histologies. then the variation with the reference standard starts increasing dramatically. So for example, if you see the variation in this particular different data sets did not exceed more than 40 to 50% in most of the scenarios. So the agreement was a problem. There are a lot of things that need to be done to really go through all of this. And currently, most of the things that we are seeing are essentially in the early stages. So most of the papers that are published at this stage, whether training, internal and external validation has been done. But a lot of things happens after that. Model packaging and the clinical prospective testing, retrospective testing happens on curated data sets, while actual in real life you don't have curated data sets, you get different kind of patients.
Dr. Swapnil, 1 minute.
Sure. You also need large volume data, thousands of patient data and thousands of slides to really reach any significant value. And the quality control of slides, the staining, the artifacts, and the scanning methods also affect the outcomes. I'm going to skip a few slides and show the problems. One of the problems is the size of the amount of data that it generates. The pathology image generated is around 2 GB per file or per slide. If you actually digitize, let's say, TMH data, we would need 1 petabyte of storage per year, just simply to store the data and not do anything else with it. So this is a lot of problems, even simply with the starting and logistical nightmare. Once you actually have a working model, there are a lot of other things that the model itself alone is not enough. You need a lot of pre-processing models and post-processing models to be built into the pipeline to really do the work. So do all of this. When we realized that there's a lot of work required to really even do the pre-processing steps, we went ahead and did this kind of a project where we are putting in timeline information of patients from the date of diagnosis to the actual date of death, including the radiology and pathology images and treatment and outcome information, along with labels from 4 different cancer centers into a single database. We're also building a lot of models for quality control in this particular case, and we have really shown in this that if you use quality control mechanisms as the pre-processing steps, the accuracy of downstream models keep increasing dramatically. We also need a lot of annotations, and this is one of the methods that we have tried to increase the volume and the rate at which we can get annotations. This is a reporting platform for pathology. And the pathologists get this pathology-based reCAPTCHA instead of the Google reCAPTCHA of marking buses and things like that. And then we convert this into a lot of annotations on the histology images, and then train downstream models to do all of this. This is just an example, a summary slide of the entire work that is happening in the Cancer Imaging Biobank project. And that is it largely from my side. This is the team that we work at ACTREC. There we have a computational path lab, AI imaging lab at ACTREC, and our aim is to not just build models and do research, but also try and translate and push this into clinical testing and potentially into clinical usage. Thank you.
So you said that the cross-cohort validation is a big bottleneck in AI and digital pathology. So why do you think that would be a problem for a different cohort within India? It's a homogeneous population and, homogeneous.
So one thing, what differs from traditional genomic tests is that if you do have a method for, let's say, EGFR mutation testing in lung cancer, the same method would work in breast cancer also, and the same method will also work in some other cancer. The method doesn't change, okay, based on the cancer type. The quality of the block from multiple tissues will affect as to what results you can get out of it. On the other hand, the digital is very specific. What you have shown the model during training is the only thing that it will test work on. So if you're used only lung cancer data of, let's say, only adenocarcinoma, the moment you change even slightly, adenosquamous or only squamous, or put neuroendocrine tumors into the mix, or do something else with it, or change the quality of the slide. So we have shown that if you take the same slide, scan it on, let's say, Leica scanner versus Hamamatsu scanner, the image quality is different. And because deep learning, most of the deep learning methods are more of a black box, so exactly what is happening inside is not very clear. we don't really control what the model is focusing on, whether it is focusing on the related things that it might happen that most of the EGFR negative ones are resections, while most of the EGFR positive ones were biopsies on during training, and the model latches on to all of this relative differences, and in the prediction, then inferencing it fails in significantly. Technical parameters, and then there are other parameters. For example, as I said, there are a lot of carbon pigment in the patients from India as compared to the Western data sets. You look at the tissues, there is very little carbon in those. So that also affects the model.
So nice to feel that in India we are doing such good things. So my question is, so is it only in lung that the area under curve is lesser? Because if you look at the prostate or other data from Western this thing, so they are claiming 95% accuracy in detecting BRCA or the pattern of prostate cancer. So is it this is only for lung, or have you done this in other cancer type of this thing?
Yes, so we work extensively in head, neck, and thyroid cancer. The general thing is that depends, a binary problem is still easier to solve. A more multi-class classification is more difficult. Second thing is there are some genomic mutations which have clear morphological correlation. So for example, HER2 has a clear morphological correlation with what the tumor looks like. Even a pathologist can sometimes say, even if the result is negative, no, this looks like they should have been positive, we'll send it again for retesting. There are certain
IHC HER2 or just
IHC HER2 also.
IHC HER2, you are saying, no?
So,
Yeah.
so the HER2 prediction is much easier task as compared to EGFR mutation prediction.
Yeah.
So this is the differences are not only about India versus Western, it is about the task that you're taking into hand. Now, prostate cancer, the Gleason grading is a very well-defined, nearly mathematical task, where the type of glands that are to be included in each each pattern is very well defined. It has been used for a very long time. There are no overlaps in those classifications. So there, it is a much simpler task.
Yeah. Dr. Amit, yes, last question.
There is some heterogeneity. For example, most of our patients are 4+5 in India, while most of the Western data sets, you look at, they are 3+3 and 3+4, basically because they have a lot of screening programs in place. We don't have, most of our patients present with metastasis, we hardly have any prostatectomy. They have prostatectomies being done regularly. Different. And we need our data to work on. We can learn, some of the things can be transferred, but then when they transfer, they won't work exactly the same. Even to use them straight away, you need to test them first.
Right.
What is happening?
So, Swapnil, I mean, on the same lines, I had that question with regards to the, I mean, this is great that what is being done, but with regards to the universality of it, the universality, for example, majority of these training sets are on higher quality slides. With good tumor content, I would imagine. But majority, what we tend to get to see in the clinics, you would know so better than all of us, is that what is the actual tumor content.
Correct.
And then secondly, the heterogeneity of the clones. We know with the spatial part that how heterogeneous it is. So, and that would be so much variable. So with these tools being made, I mean, of course, the answer lies in the denominator that what you're training with. But what is your take that how universally applicable such technologies that you anticipate in the times to come?
It is not universal in the way we would like genomics works, that the same method you take here and you start doing, the interpretation of the data will change, but the results are still the same thing. You get the same result. Over here, the method itself is also going to change. The moment you work from Western population to Indian population, or even within a heterogeneous population like India.
Yes, within India, yeah, that's what I was kind of.
I feel very stimulated by this talk. I feel the genomic data and AI would do better.
AI things will work in a lot of different ways. For example, heterogeneity analysis is significantly better done with AI-based methods and easier to do. Not that it's practically impossible to do genomic sampling for multiple areas. Obviously, NGS have its own bioinformatic methods to assess heterogeneity. But essentially, it's again coming down to some computational method to work out the heterogeneity. So now this heterogeneity is working on the image itself.
But the solution is if you combine genomics with AI.
That's what I
Yeah, again, it's not, so nothing is a replacement for the existing methods.
The
It is,
CNS methylation class.
it is not a
sarcoma,
replacement.
It's already there.
It is simply a additional method of doing it. With at least for a certain proportion of patients, will reduce the time that it takes to start treatment.
Thank you,
Thank
Dr. Swapnil, for a very